All right. Thank you, everybody, for being here today. Today's webinar is Unlocking Better Healthcare in 2024, Integrated Remote Care Management for Rural Health Clinics, and it will be presented by Azalea Health and MD Revolution. Our two presenters today will be Douglas Swartz with Azalea Health and Paul Huffman with MD Revolution. Douglas Swartz helms the back office revenue cycle management service division for Azalea Health, focusing on maximizing revenue, profitability, for Azalea clients. Swartz has experience in healthcare administration and RCM dating back to 2003. He specializes in the management and scaling of RCM operations using best practices, workflows, and KPIs for healthcare providers in over 30 different specialties all over the U.S., including a focus on rural communities with critical access hospitals and rural health clinics. He holds a bachelor's in business administration degree majoring in finance from Valdosta State University, where he received the Gold Alumni Award in 2008 and is a certified healthcare business management executive through the Healthcare Business Management Association. Doug is an active board member of the Valdosta Habitat for Humanity affiliate and the Valdosta State University Langdale College of Business. Our second presenter is Paul Huffman with MD Revolution. Paul manages MD Revolution's Medicare fee-for-service programs with nearly 20 years experience as an accomplished healthcare executive working within outpatient clinics, large health systems, and multi-specialty practices. Experienced in sales and company growth, Paul leads the identification, development, and execution of new business opportunities to expand our footprint within the marketplace and drive business results. Paul is the former co-founder and president of Falcon Care LLC, where he grew the organization into a leader in care management with the implementation of on-site preventative service programs within outpatient centers. Prior to Falcon Care, Paul was VP of Sales and Delivery for Symbiosis Health, acquired by StatPay, and VP of Sales for a large regional laboratory in Chicago, where he was in charge of building an elite sales team and generating strategic growth outcomes. Thank you guys for being here, and we can go ahead and get started if you're ready.
Thank you for that intro. That was great.
Mm-hmm.
Yeah, really excited to be here. We at MD Revolution, we really focus on delivering remote care programs, both RPM and CCM, and now transitional care management as well. We've served about 160,000 patients since our founding in 2015, and we really are an extension of the practice in the space and developing and also scaling those programs within our partner organizations.
Yeah, and thank you guys for having me. Again, I'm Doug Swartz. I'm a co-founder at Azalea Health, and we're a cloud-based electronic health record system and revenue cycle management services company with integrated telehealth services. And we were founded in rural South Georgia. That's where I'm at today in Valdosta. And we have solutions focused on both ambulatory and hospital and rural areas. Our mission as a company is to help underserved healthcare providers improve patient care and profitability. So I'm really glad to be here.
Great. So for the first time, Medicare has proposed some changes to the way that they compensate rural health centers and also FQHCs within this space. Previously, Medicare took all these care management at the time CPT codes and services and bundled them into one code, G0511, back in 2019. And at that time, that was to encompass chronic care management, behavioral health integration. Now we have principal care management. All those really got lumped in to this one code. And so it was the same reimbursement for 20 minutes of work, but then the same reimbursement if you had 60 or 70 or 80 minutes of work with one patient each month. Now, for the first time, they're going to add remote patient monitoring into the mix as far as a reimbursable service and code. We do believe that right now they're suggesting a slight decrease in the conversion factor of that reimbursement. But the good news is for the first time, our HCs and FQHCs will have the ability to get reimbursed for these remote patient monitoring services. So when you're looking at different care programs, different companies to implement, whether you're going to do it in-house or you're going to outsource with a third party, there are really some key differentiators in the marketplace and benefits that each of those companies may provide and what you should look for. You know, what are they trying to solve, especially in our RHC setting? There's some unique situations and challenges for our RHCs. So when it comes to RPM or even chronic care management, you want to really work with someone who knows that what those challenges are and can help with those obstacles. And then what do we need now to make that financially viable? Now that it is going to be a reimbursable code next year, it's not just going to be covered from a grant. You're not going to just have to kind of bundle it and encompass it into your CCM program. We now will have this separate code. And how does that work in conjunction with chronic care management and any other care management, case management programs you have within the clinic? So post-COVID, remote care, it's here to stay. There's a lot of comfortability within practices and providers, but also patients now are a little bit more comfortable with telehealth, remote care in general, and getting some type of outreach or interaction or connected care from in their home with their clinic. So it's really a different mindset, and it has really propelled us to kind of the next phase of remote care. So now what do we do? Well, there was a survey with about 680 physicians that Deloitte administered that 83% of physicians expect there to be some type of patient-generated data from wearables, apps, devices in people's homes, integrated within their care delivery system within 5 to 10 years. But a lot of those practices and providers aren't doing any sort of outreach or connected care at the moment. That same survey said that about the same percentage of patients believe that care teams will be sharing the data between patients' health data and other teams in some sort of streamlined way. And then also physicians also estimate a third of physicians also estimated that their work could be performed by a non-physician outside of the practice and outside of the clinic. But who is providing that care, and how, as a provider, how can you control that and make sure it's the care that you want your patients to receive? So like I briefly mentioned, there are a lot of implications post public health emergency, a lot of changes during really quickly, broad coverages for telehealth, broad coverages for remote care. And now those have been dialed back a little bit and clawed back. So we are going to see an extent of those waivers through 2020 or extended to 2024 for telehealth for established patients. Medicare really still wants, though, that patient-doctor relationship to start inside the practice, but then to be continued outside via telehealth. How are practices now dealing with not only the post-pandemic implications, but also financially catching up to some of the challenges faced during the pandemic? And with some of that revenue or some of those funds being clawed back by the government as well. We're also seeing that great resignation, staffing, keeping quality staff, but also providers within clinics is becoming harder and harder and more of a challenge. So how do you choose the right vendor for remote care programs to extend from your practice? How do you make them an extension of your clinic and your rural health center? So, and coupled with all that, now we're now needing to expand the number of employees that need to be put into the system and expand the number of physicians. They're expected to need over 1 million more registered nurses by 2030. And there's expected to be about 100,000 physician shortage by 2034. So those are unique and large challenges that sometimes even are exacerbated by rural health centers. So how to, inside rural health centers, this is a unique healthcare landscape for RHCs and then also FQHCs. Sometimes they wrongly get lumped together, but rural health centers provide a very unique challenge because there's obviously there's a lot of different pay structures, billing rules, financial challenges. Typically we see sicker patient populations with higher mortality rates. And then there's a disproportionate strain on resources and people based on geography. It's hard to recruit, it's hard to retain staff and also providers as well. So how do we then take this new opportunity or this expanded opportunity with remote care and make sure that we have a continuity of care with the patients in the practice, and also make those financially viable when they're being implemented, right? It has to have all of the pieces in place. It can't just be this great interactive program for patients, but it's also got to be beneficial for providers, and also has to be financially viable. So in 2019, that's when these codes first came out that were specific for RHCs and FQHCs. And again, they bundled all the services at the time, took the average reimbursement for those services, and that's where they got the reimbursement for RHCs. And then at that same time, there was an increase in grant funding by HRSA grants to administer these remote care programs. And that's where we as MD Revolution have really lived within rural health centers and FQHCs when it comes to remote patient monitoring. And we've been able to then implement separate chronic care management programs that are reimbursable by this G0511 code, and then separate, really tailored for RHCs and their grant funds, a RPM program. So those are going to change a little bit because now you're going to be administering these RPM programs not under these grant rules, but now under these fee-for-service rules. So at the way that we do it and the way we do it differently, MD Revolution, we really feel like chronic care management, traditional CCM, traditional care management, BHI programs are really better together with remote patient monitoring. Patients really don't care what service they're getting. All they know is they are getting a health coach that is calling them about their care and their medications and their visits and healthy living. And at the same time, someone's monitoring their vitals and they have this device at home. And so when we roll these out into fee-for-service programs, we see lower attrition rates, we see better buy-in from the patient, better outcomes, and we're able to complement the two. We're able to then provide these devices in home that we're monitoring their vitals, and then the health coaches have additional information and talking points with the patients. We also couple that with wearables. So we're integrated with Apple Watch, any wearable Android device in the home, a lot of at-home devices like Omron cuffs or Withings or iHealth. All this bundled together is a 24/7 seamless connection and data points for our care providers that we can push back to the providers in the clinics. And I'll show you how that works within our partnership with Azalea as well. So what are those advantages for RHCs? Well, we're able to integrate their care management program. We're able to push back all that clinical data, including vitals, into the EHR and into the patient's chart. We provide greater accuracy for vitals in the home versus self-reported vitals. And then we see it, like I said, these dual programs are better retention rates. We're able to scale them more quickly and get better buy-in. And it's just more data points for physicians and providers as well. I really thought RPM would cannibalize our CCM business, but what we've seen is just a greater buy-in and lower attrition rates from patients. So when you're choosing an RPM program, it's really important that you look at the type of the devices that they use. As a company, we're device agnostic. You know, if you've already purchased a lot of these devices based on grants, we can integrate those with our system. We are integrated with over 250 different devices. But if we're going to provide traditional remote patient monitoring care and we're launching it into people's homes, we really want those devices to be cellular devices. We want them to be hub devices. And in a lot of cases, our hub devices that you see here are actually integrated with the personal emergency response service, so what we call PERS. Patients can call for emergency services if needed. There's a 24/7 operator, and based on protocols that we establish with our clinics, can provide additional care and resources for the patients. So again, those just add to the buy-in and the usage of these devices and people actually taking their vitals and using them. And they can also wear these pendants throughout the home in case they do have an issue. At any time, they can reach anyone at any time as well. And then we can also integrate this and how do we define success within our clinics? Well, having a true data integrated partner with the EHR is key. So we have bi-directional enrollment services within our Azalea integration. We exchange health history, but also all of the care summaries and interactions we have with the patient are pushed back into Azalea each month. And then we were also pushing back discrete vitals data in real time back into the patient's chart. This is key to an effective program. Your providers know what is happening with the patient in real time. We're not pushing alerts back in real time. We're handling those usually as a service for our clinics, but that data is there. It's discrete, it's searchable, and it's also a way that we can measure outcomes. If we have a defined success going into these programs, we can pull that data and show how our outcomes are providing for the patients as well. Now I'm going to turn it over to Doug to really dive into the RCM business and how Azalea supports that.
Thanks, Paul. So, like Paul mentioned, having a vendor partner that really understands your space, that is tailored to your needs, and if you're looking at adopting, remote patient monitoring, chronic care management, something that's integrated, because there is a lot of additional overhead involved in running those types of programs. And at Azalea Health, I think we have that partnership with MD Revolution, and I think there's a lot to be gained from it. So I mentioned this earlier, but Azalea Health, we were founded in rural America. I'm in Valdosta, Georgia. The company started there in 2008. We have 300,000 unique users and about 20 million patients on our databases across about 15,000 providers. So we started the company in 2008, and first couple clients we spoke to were independent and provider-based rural health clinics. So we started building out UB split billing functionality as early as 2009, and we've always been in the cloud. So and you can imagine back then, speaking with rural providers, internet wasn't as great. Even today, it's still not perfect, but it's come a long way. And we work with a lot of different rural health clinics across the United States. So independent, provider based, a lot of them are in the Southeast, Mississippi, a lot of them are in Georgia, all over the place. So we understand the space really well. And recently we've really upgraded kind of our RHC billing capability. So I already mentioned we got UB 1500 billing that we could support in the application. We have analytics tool that can help you track your qualifying visits and separate those from visits that don't have a qualifying visit. We're able to easily export data for like bad debt, immunization reporting, for cost reporting, help you avoid penalties and get that maximum reimbursement. So we really upgraded our bundling functionality this year to make it easier to bundle your visits together on your outbound claims. Now that is part of our service as well, including we have an automated CG modifier that we turned on this year. We also have a combined encounters lookup tool. So if you are, you got nurse visits or things that can't be billed out and you want to hold those for that 30-day period trying to find a qualifying visit, we have a feature that allows you to do that pretty easily. So we also have a alert rules engine library, and I don't know off the top of my head, but we have a lot of different custom rules specific alerts, hard edits, soft edits for rural health clinic specific billing. So like I mentioned earlier, you're going to see other systems. You may be on a platform now that has this functionality, but they're not going to be, they don't understand the space as well as Azalea Health does. So then on the next slide, to me, expand a little bit on the billing as a service. So we have the software, and I talked about the capabilities there, but we also have a service, and it's US based RHC professionals. We have within our RCM service division, we have an RHC team that's all they do is RHC focused claims, denials, reimbursement, appeals. Several of them are certified through the Rural Health Clinic and Billing Specialist certification. We do pay for that for our employees. So the Association for Rural and Community Health Professional Coding. And like I said, we've billed for over 150 different RHCs across the US. And what makes us unique is if you sign up for our RCM services, you get our software included in the price. So, and if you want to go to the next slide, Paul talked about the burden that healthcare providers face. And if you think through COVID and even prior to COVID, we were seeing a decline in rural hospitals, which was reducing access to healthcare in rural America. And it is part of our mission as an organization to address that. You only had, I think we saw this on our previous slide, 4 in 10 rural hospitals have negative operating margins. So, we're probably always constantly thinking of different ways to increase revenue, reduce cost. And the rural organizations in particular, are burdened by this, and, having, being able to maximize your reimbursement is one thing, but then how can you get additional better outcomes, quality of care, and make extra money? And then I think that's why we're all here, is to talk about that. So that's what I was going to focus on here. And if you go to the next slide, you think about better tailored technology. So a lot of physicians look at the technology side as, oh, this is an extra burden on me, more clicks. But what if you had something like an integrated solution where you didn't have as many clicks, you weren't having to scan and manage the documentation quite as much. The claims were automatically dropping. You got document integration, which is what we have with MD Revolution. And then you can get those claims to automatically drop. And that's what we have. And Azalea Health as an organization, we started out as a billing company first, and we designed the software around the billing service. And then the clinical piece came next. So our software has always been an enterprise level solution from day one. We didn't go out and acquire different pieces and kind of merge them together. And during a recent study, we were talking about clicks. Our software on average is about a minute faster than our competition when it comes to posting payments, charting, scrubbing claims. So we feel like we're addressing the burden of the software usage, and we're also knowledgeable enough in the space to help you get reimbursed for these additional services like remote patient monitoring, chronic care management. Sorry, I had to clear my throat. So, and to give you some evidence to kind of go with, and this is something to think about, because I know not everybody on this call is billing for. Maybe you're thinking about, or you've dipped your toe in the water a little bit about, how do I set up this program? How do I get paid for these programs? So I went and looked at our existing kind of customer base, and I found out of our RHCs, about maybe 25-30% of them are currently have one of these programs in place and are billing the G0511 code. I found some in Georgia, Mississippi. I found a couple, Missouri, and what I found was an increase of reimbursement through billing this G0511 from anywhere from 5 to up to 30%. And so just to give you an example, the one that did 30%, they've really got their ducks in a row in terms of getting all these patients onboarded with the program, getting the consents, and making sure those monthly visits are happening. And it's through the MD Revolution partnership. Nothing slipping through the cracks. It's not as an administrative burden. In this particular practice I'm looking at, their AIR is about $120. They're seeing about 500 patients a month. And their Medicare population is about 43% of their patients that walk in the door are Medicare. And they are getting an extra 30% in reimbursement every month through this program. And so then I went and looked just deeper to see, like, an individual patient level, what does that look like? So I found a patient, he had 4 to 6 chronic issues. You're talking heart disease, hypertension, chronic pain, sleep apnea. And his visit history where he was actually coming into the office is about quarterly. And so through that, they were, $700 to $800 in annual reimbursement through the office visits, but then we were getting an extra $900 a year through billing that monthly G code. So instead of getting around $700 to $800 a year in reimbursement for this patient who had several chronic conditions, and we were doing a lot of work and trying to improve outcomes, we're getting $1,700 instead of $800. So, and that's just one example. And I know not every patient qualifies, and only one provider can bill for it, but that's an example of an organization that really took the effort to make sure all their patients were qualified, they were enrolled, they were leveraging the technology and getting that extra reimbursement. And then the patient is getting better outcomes, they're having a better experience, and have a better relationship overall with the practice. And I thought that was just fantastic. And I had several others that I was just picking through the different organizations that we work with that bill for the G0511. And that's today. And I know the reimbursement may drop a little bit, but still it's significant.
That's great. So the way that it's changing for next year, we know what Medicare has proposed as an entity that we've also responded to some of those proposed rule changes for next year. So I'm kind of going to go through what's been proposed, what we asked for, and where do I think the rule is going to land for next year. So as per usual, CMS has been a little ambiguous on what they plan on doing for next year, but we do know that RPM, remote patient monitoring, will be reimbursable as a service. So some of those numbers that Doug pointed out, which are great, really pertain to CCM only, right? So now we're able to add remote patient monitoring, and based on what Medicare has said, we believe that RHCs there's going to be an effort to bill for both services for the same patient in the same month, just like you can do with regular freestanding fee for service clinics in the regular Medicare fee schedule. So if that happens, then now we have patients that are getting both services. But also what we've shown when we've done that on a lot of our other clients is that we get generally more patients are in the programs, and they're in the programs longer. And then we can also measure outcomes for those programs as well. And we have vitals data now and we'll have it to back it up. So we've advocated for against these rule changes a little bit. So right now, the recommendation is to allow providers to submit claims for multiple services under this G0511 code. So if a patient is in both programs, then you can bill for G0511 once, twice, possibly 3 times, because there's a device code with remote patient monitoring, and then there's the monitoring code. Now, right now, that the device and the clinical code will be separated and billed separately is what we have then responded and asked for to CMS, because they should be treated differently. You want to incentivize and get patients and providers to get the patients to use the vitals, and then you need those vitals to then review them as well. So one is really kind of a technology service and interaction with the patient, and then the second one is review of those vitals and intervening when necessary. And then in addition to that, if the patient is in and been enrolled in chronic care management, and then the health coaching and the care plan being developed, maybe connected devices and wearables in the home, lifestyle devices, all of that is also reimbursed separately. So the recommendation that we have made is to keep the current rate at $77.94 for all RHCs and FQHCs under that code. And that any decline in that reimbursement is de-incentivizing rural health centers to participate and make the effort to get these patients enrolled. And then another recommendation that we've proposed, that this is the one that I don't think will actually take place. Right now, the code reads that there has to be 16 days of connectivity input, readings, and alerts each month in a 30-day period. Now, we have proposed as an organization and also as an industry as a whole to reduce that threshold to 10 days of connectivity. During the public health emergency, it was only 3 days. And so that reduction to 10 is almost a middle ground between what it used to be during the PHE and what it is today. And so I don't think CMS is going to allow that. I think they're going to deny that request and keep it at a 16-day minimum threshold. And require that in order to bill for the device, that device CPT code, or that device reimbursable code. In the Q&A, I'm just going to run down it real quickly, and please feel free to either in the chat put your questions, and we'll moderate them and answer as many as we can. If we don't get to them today, we will email you back and answer those individually. But we always get asked what are the typical costs for a remote care program. Well, we now, for our Forest Service clients, it is on a contingency basis, whether these services get billable or not. We do provide a SaaS solution as well. So if clinics want to use our care management platform and our device integrations and fulfillment, they can do that as well. And again, that wouldn't be on a per billable or per service completed. It would just be for the software and use of the platform. So typically you can see anywhere from a 40 to 50% return on your investment, depending on how involved you are in both services. And then also we can help scale those programs to get patients into them as well. And we usually, with Azalea, what's nice about the integration, because they are cloud-based, that Doug mentioned, it is a 1-to-many ratio. So we can usually launch a clinic within 4 weeks. So we have a very set implementation process. And part of that implementation process is training and provider and staff awareness. But it's also setting up and testing the integration and making sure that not only its clinical data is going through, but also that the claims and the billing are set up properly as well as documentation back into the patient's chart. I've already mentioned about software only options, and also if you do have value-based initiatives or grants or outcomes that you want to go into to prove out, we always like to know those as we're launching the program, so we can make sure that we're providing the right feedback and also going into it with the right data as a partner with our clinics. Do we have the ability to show outcomes and to track that data? So we use Tableau in the back end for all of our analytics and reporting that allows us to really slice and dice that data in an effective manner to prove outcomes. And that also allows us to do gaps in care initiatives. So if you are in a value-based initiative or contract, then we can translate gaps into care into tasks for our clinical team, and then prove back on which gaps got closed and for what patients as well. And really, if we're doing the full service for a clinic, there aren't additional FTEs needed within our partner practices. So we really just need a clinical champion, a clinical and provider champion, also administration champion. Why are we doing these programs? Why are we implementing them to our patients? Really show the staff and everyone else what the goals are for the program and what the initiative is really set to accomplish. That is what we mainly need, and we need a point person inside the facilities as well to help answer any questions, monthly check-ins and feedback, and help us implement those programs. I'll also open it up to any questions if there are any in the chat, and I'll leave it to our moderators to help facilitate those for either Doug or myself.
And I'll just add on to that before we get to questions.
Great.
You're thinking, you're taking the information from Paul and you're considering it. I mean, I would definitely, I think it behooves you to at minimum research, what is this going to take? What's the cost? And if you were wanting to do like an ROI, like an analysis internally, I mean, one thing I would suggest is, if you can, most EHR systems now, you know how many patients are you seeing that are Medicare Advantage, roughly how many of those have, enough two more chronic conditions. And then we know what the reimbursement is. I gave you an example earlier. You've got someone that's coming in, maybe it's every other month, every quarter. How much more could you earn if you were successfully billing, even right today, but we don't even know what's going to happen with the proposed rule. But even today, you can only bill for it once, but how much extra money could you earn from that now? You could even be conservative with it and then compare it to the costs, talk to Paul, figure that part out. And then, I think it's a pretty easy kind of internal thing you could do to determine if it'd be worth it. And I'm pretty sure when you sit down and do the math, you're going to find that it's worth the investment.
Yeah. And I'd like to just add to that, Doug, our integration with Azalea is uniquely has some advantages in the marketplace. And obviously, the real-time vitals data is something that is a distinct advantage in the marketplace, but also knowing or working with a partner that understands RHCs and FQHCs, even though we've talked about this G0511 code, that's for traditional Medicare patients in general. But then also there's a unique challenge sometimes with RHCs where they have a contract with Medicare Advantage plans that say follow the Medicare fee schedule. And this G0511 code is actually a separate carved out code that's not on the traditional fee schedule. So sometimes we need to translate those codes into the traditional fee schedule CPT codes to make sure that rural health centers get reimbursed with their Advantage plans as well. So uniquely going in, what are your contracts with those Advantage plans or private payers actually, and then comparing that with your traditional Medicare patients. So there's some nuances and unique situations with RHCs that Azalea knows all too well and knows very well how to implement those as an RCM partner in EHR, and then what we've worked with as a care management partner as well. So we know what to ask and to look for before you even start.
I do have some questions here in the chat, and anybody also feel free to unmute yourself. We can open this up to a discussion. First one I see here, can RHCs outsource enrollment services? And if so, what enrollment rates are you seeing when AV Revolution handles the enrollment for the clinic?
Yeah, that's a great question. So that the topic of enrollments with RHCs has really been a ping pong the last few years. So when these codes first came out, rural health centers could only enroll patients on site. So it had to be with an individual within the clinic under direct supervision, which really was a challenge for these centers to really scale the program because there's a lot of things going on within those centers, and enrollments for these programs sometimes is the third or fourth thing that gets remembered and also takes priority, right? So during the PHE, we were allowed to enroll under general supervision. So that allowed us as an organization to get lists, to get protocol sign-offs and for all eligible patients, and really launch enrollments and scale these programs for our clients faster and better than we ever had before when it had to be done on site. And so when we've done that, and we do that for all of our clinics across the country, including our HCs, and typically we're seeing from our teams and enrollments, we're getting about a 26 to 30% enrollment rate, and which allows us to really launch these programs very quickly. Now the PHE has ended, and general supervision is no longer allowed for rural health centers. So for right now, we're back to direct supervision for enrollments. But these proposed rule changes for 2024 are actually set to revert back to allowing enrollments for general supervision. So in January, we as an outside organization will be allowed again to spark remote on outreach efforts for our clients to spark enrollment. So it's good. It's great timing. So for any new clients we're bringing on in October or November, then we are already planning on these launches in January for remote enrollments.
All right, thank you. All right, I got another one here. What type of devices do you typically recommend to our HCs if we haven't already purchased?
Yeah, there'll be a copy of this deck available for everybody. But on that one slide, we've used a lot of different devices. We've partnered with a lot of different companies out there. And if you go with our integrated device and hosted device, it's a hub device that's cellular connected. So having that hub in the home allows us to call the device directly. It allows the patient to call us directly. We can leave voicemails, alerts, reminders to take their vitals, and they're cellular connected. So you do need a cell phone tower that can connect, which what happens too is with our vendors, there's a cellular coverage map that is overlaid with zip codes and before it's shipped out. So we know if there's any gaps and can go with a secondary choice for some patients if there's not a cellular connection in the area. But devices that just have a chip or Bluetooth or Wi-Fi or need an app to really be functional do not generally work and aren't scalable because there's just an extra barrier for the patient to use.
Great, thank you. Anybody else have any questions? Give it a second here. Okay, there's one more. Can you describe the practice view a little more around the clinical documentation? Is there ever a need to interact with your software, or am I only clicking through my EHR?
That's what's great about our integration with Azalea. It's a two-way integration. So our care team lives in our software, and your care team, the providers, live in Azalea like it should. We push the claims into Azalea, monthly notes, clinical information, documentation, go back into Azalea. Based on protocol sign-offs, our clinical team will reach out if there's any escalations needed back to the practice. That goes with monitoring and calling the patient and assessing symptoms, all the way up to medication needs or appointments and reminders and alerts from our clinical team as well. So that two-way integration allows for each of us to live in our own worlds. Patients do have opportunities to download our patient app where they can see their vitals. They can message and interact with our clinical teams. But again, they can just use that separately from the EHR and separately from reaching out to the clinic. So both ecosystems talk to one another and have a two-way integration, and at the same time, no need to log into both.
Great, hope that answers your question. Do we have any more questions? Don't be shy, we can unmute and have a conversation. Feel free to. Right. If there aren't going to be any more questions, we are recording. So if there's anything I want to add for anybody who might come back and watch the recording later, anything like that, don't have any questions, I think it'd be good to adjourn. I think that might be all for questions, guys. Thank you all for being with us today. Would have liked to generate more conversation, but everybody's a little shy today. We need some more coffee this morning. All right. Well, thank you all. And we will have all your slides going out to everybody. We'll have this recording being sent to everybody as well to review. I believe y'all's contact info is there as well. So everybody can get in touch with y'all.
Thanks, everybody. Our contact information are on those slides, so feel free to reach out if you had something you wanted to follow up with us directly.
All right. Well, thank you everybody for being here today. And everybody enjoy the rest of your day.
All right, guys, take care.